if it fails, what am I going to do for my re-op? And I do that first.
That's a nice way of thinking it. Devash, is there any comment of your standard procedure for macular hole surgery? So you do inverse flap for all of them, or you do just a standard ILM peeling and fluid?
Actually, I look at the OCT very minutely. If I see the whole height is very high and basal linear dimension is less than 1000 micron, I do not do inverted flap. I just peel the ILM. And most of the cases, they close nicely. And if the basal linear dimension is more than 1000 and whole height is very short, then I go for inverted flap. I've never tried any plug-in kind of thing that most of the people
Not as a primary surgery.
No,
not
no.
as a primary surgery. Yeah.
Dr. Stewart, behind you. So what is your indication of doing inverse flap in a macular hole?
Yeah, I've not done reverse flaps. I'll do peeling, and then generally I'll do a free graft. But I tend not to do reverse flaps, so I bypass that step.
And if it fails, then what is your methodology?
So if my free graft has failed, which is usually not my first case, but that's my second case, if that fails, then I go to amniotic membrane.
Thank you.
Stuart, I have two questions. One is, how do you plan your free flap surgery? So you take it from there, you put it under PFCL, or do it directly under FG? So how do you do that in free
Yeah,
flaps?
I don't. What I find is most of the free flaps, once you get it onto the fovea, there seems to be some sort of adhesion. And I don't know exactly what the forces are, but if you make sure that you don't have a lot of fluid going through the eye, and very carefully, you can stuff it in the hole and it stays there. And then when I do my air fluid exchange, I do it very carefully to keep the cannula far away from the hole to make sure that I don't disturb it. But I find that it stuffs in fairly well, and you don't need anything special. And you don't have to do it under oil or under PFC.
Okay. Do you have any experience about this hydrodissection of macula? It's being given in multiple papers about the most hydrodissection of macula in recurrent macular holes.
Yeah, I've not had experience with that. I can see that if the edges are flat, it would make sense, but I've not done it. Are you talking about going through the retina?
Yes.
Or going through the hole?
Going through the retina.
Yeah, don't go through the hole. Yeah, what you can do is you can elevate the retina and you'll lose all your RPE at the same time.
Yes.
So yes, go through the retina with a small gauge cannula, probably in multiple different quadrants, and then the air fluid exchange to come down.
Yes.
I've not done it, but I think it makes sense for those holes that are flattened without elevated edges that you don't think are going to come in together.
Okay. Oh, thank you.
Sir, what about massaging the edge of the macular hole? Some people try massaging.
Yeah, I don't do that. I worry that more times that I touch the retina, the more times I might damage the retina. So I tend not to do that. I know people do it successfully. I have not done it.
Sir, hello, sir. Sir, I have a question. Sir, in small macular holes like less than 250 RD stages, do you have any experience? Is only doing PVD, not having touching the ILM, only PVD?
Yeah, so I can't give you a series. The last one I did was PVD, and I did ILM peel as well. It was a very small hole, and it closed beautifully. So I still do ILM peel in those, although I think an argument might be made for not doing an ILM peel. I do it.
Just for a routine retinal detachment surgery, do you prefer for pneumoretinopexy? Is there any role of pneumoretinopexy in your clinical practice?
Of pneumatic retinopexy?
Yeah.
I almost never do it.
Okay.
I used to do it, but I've gone through phases where I've seen too many failures, and I've seen other people do it with failures as well. And we know, at least statistically, the success rate for pneumatic retinopexy is less than that of vitrectomy or buccal. So I tend not to do it. The only time I could see doing it is very late on a Friday afternoon and I'm traveling or there's no OR or something. But generally, for most of the primary detachments, my first choice is always a buckle, preferably a non-drainage buckle if I can. And then I look and see, is that not going to be fit for this case? And then I do a vitrectomy. But buckle first, at least in my mind, and then I'll move to vitrectomy if I don't think the buckle is going to do it because of the location of the tears or et cetera.
Thank you. We're ready to go. Okay. So this is, in fact, when we heard the name of Professor Michael Stewart, so we didn't have any doubt of, about the today's program or this evening program. And this name is sufficient enough for his introduction. But as a customary, let me first, welcome you to Kolkata first, because this is your first visit to Kolkata. So we welcome you. But again, he is frequently visited to VRSI, and most of the time we do see him in VRSI. And probably in this year we are going to come to India for 3 times in India. That's very frequent visit for you. And Professor Michael Stewart is the name around the globe. And he is a professor and chairman of ophthalmology in Mayo Clinic, USA. He is a renowned retina specialist and clinical researcher. So with over 3 decades of experience, his pioneering work in retinal vascular diseases, anti-VEGF therapy, and the innovative treatment strategies has significantly influenced the retina practice worldwide. And a lot of us who are present here, we do listen to him and decide our practice pattern as well. A prolific researcher, respected educator, mentor, Professor Stewart continues to advance retinal science and improve the patient outcomes globally. Sir, the podium is yours, and we are eager to listen to you. Thank you, sir.
Well, good evening, everyone. For those of you here in Calcutta at the hotel, and those of you who are viewing remotely, thank you very much for taking time out of your evening to be here. It's a pleasure to be here. I'd like to thank the West Bengal Ophthalmology Society for inviting me, and also Bayer Pharmaceuticals for facilitating this. So my talk is going to actually be fairly wide-based. We're going to make the pivot now from these wonderful surgical cases we've seen and now talk about chorioretinal vascular diseases. And I'll touch on several different aspects. That this will be, a lot of this will be data-driven, but it's not going to be much of the study type of data that you're typically seen in the past, because most of that data you already know. So we'll go ahead and we'll talk about things like fluid management, switching strategies, and then talk about some of the basic comparators between some of the different drugs that we have. Not surprisingly, when I look at disclosures, I am a consultant for both Bayer and Regeneron, who's Bayer's partner with the use of aflibercept across the globe. So we're going to talk about the concept of drying of the retina. I think if we were to ask the question, does everybody want a dry retina when you treat your chorioretinal vascular diseases? Everybody's hand would go up, which is very reasonable. But we don't always get that. And we don't always get that occurring easily as we do our therapy. So we need to understand a little better what fluid is important, what fluid is not important, where we can tolerate, and what fluid we really don't want to tolerate especially within the context of age-related macular degeneration. So to do that, we say that yes, drying is great, but it matters where the drying occurs. So we break the fluid compartments into 3, and you've seen this before. Intraretinal fluid, generally, we have a lot of data now to show that intraretinal fluid is adversely related to visual acuity outcomes. Subretinal fluid. subretinal fluid is either neutral with respect to visual acuity outcomes, or it actually promotes better vision. We think it may be because the subretinal fluid actually creates nutrition and oxygenation to the photoreceptors in the pigment epithelium and helps to prevent macular atrophy down the road. And then the third compartment is the pigment epithelial detachment. In general, RPE detachments are sort of neutral. We don't really care that much about them. Many times we get improvement with our therapy, and that's fine, but we generally don't chase RPE detachments and try to flatten them unless there are two circumstances. The two that I really go after with medication is an enlarging PED while being treated. Then I think that is a risk of a retinal tear, or excuse me, RPE tear, or a RPE detachment above 390 microns. That's the number that's sort of come out of the literature. That in and of itself is a risk of an RPE tear. Those are the two cases. I'll alter my anti-VEGF therapy specifically to try to dry out or flatten the pigment detachment. Otherwise, we tolerate it. So what data do we have that actually supports this concept that subretinal fluid is actually okay to tolerate? And it's associated with at least equal, if not better vision than average in patients with neovascular AMD. Well, the fluid trial out of Australia took patients with neovascular AMD and with fluid of less than 200 microns. And then what they did was they randomized them to aggressive therapy to try to dry up all the fluid, or to therapy simply to tolerate the fluid, where they could perform a treat and extend strategy. And what they found over the course of a couple of years is that whether you look at improved visual acuity or whether you look at 15-letter gainers, the group that tolerated the subretinal fluid and in the process had fewer injections actually did exactly the same visually as those patients who had very aggressive therapy in brown at trying to get rid of the fluid at all costs. And so those patients actually got more treatment than they needed because the group that tolerated therapy did just fine. And then, of course, we bring out this question of past 2 years as we go to 5 or 7 years. Is the group with persistent subretinal fluid actually going to get a better outcome because they're going to have less macular and RPE atrophy? And that may well be the case. That's something to consider. So fluid shows us prospectively that subretinal fluid under 200 microns can be tolerated. Now, I don't measure subretinal fluid. 200 microns to me is pretty thick. It's about the thickness of the retina itself. So generally, I think that's a little more than I would like. But the concept of tolerating fluid is a good concept. From the phase 4 trials for aflibercept 2 milligrams, we have ALTAIR and ARIES. ARIES actually tolerated fluid less than 50 microns, and patients who had less than 50 microns of fluid were able to be extended, not just tolerated, but extended. ALTAIR tolerated some thickness of the retina and it tolerated subretinal fluid, but those patients were kept on standard maintenance therapy, but they weren't extended. So the fluid management was just a little bit different in those trials. But ARIES did show that patients could be successfully extended with less than 50 microns of subretinal fluid thickness. Probably the best data has come to us from Harbor. Harbor was a phase 3 trial done by Genentech where they compared the standard dose of ranibizumab, 0.5 milligrams, with what they called a superdose. The superdose was 2 milligrams. They were thinking that maybe the superdose would give superior visual acuity results to the standard dose. But what they found was whether the patients were treated monthly or on a PRN basis, the visual acuity results were actually pretty similar. And so they stopped using the superdose, and 0.5, of course, has become our standard for most of our choroidal vascular conditions. But what they also did in a post-hoc analysis was they looked at the fluid. And what they found was on the left of the slide, you see that they're looking at intraretinal fluid. And those patients who had intraretinal fluid at baseline or anywhere else along the way had poorer visual acuity results than average. Whereas on the right side of the slide, you look at subretinal fluid. Those patients who had subretinal fluid at baseline had better visual acuity at baseline and better improvement in visual acuity over time. So the subretinal fluid actually was somewhat protective and promotes better vision, whereas intraretinal fluid is actually contra to improve visual acuity and baseline visual acuity over time. So our treatment strategy, go after intraretinal fluid as much as you can, improve, stabilize, tolerate subretinal fluid. The VIEW trials in a post hoc analysis looked at the same thing, and they found that the intraretinal fluid in red was associated with poorer visual acuity improvements. Subretinal fluid in green showed that the visual acuity improvements in patients with subretinal fluid was exactly the same in those that didn't end up with subretinal fluid over time. And then when you look at the VIEW over the course of time, you see that same trend where intraretinal fluid is associated with poor vision at every time point. Subretinal fluid is associated with better vision at every time point. The CAT trial looked at this in a post hoc analysis and found exactly the same thing. This distinction between poor visual acuity results with intraretinal fluid, better visual acuity results with subretinal fluid. And I'm going to touch just very briefly on Hawk and Harrier with brolucizumab, because I know in India, you probably have more brolucizumab use than anywhere else in the world. So one of the reasons for that is people say brolucizumab dries very well. And I think everybody in this room that's used it would probably agree. It really does. It dries very well. But it's important to know where the drying is. Because when you look at the visual acuity results out of Hawk and Harrier, the visual acuity improvements were actually exactly the same with brolucizumab compared to aflibercept 2 milligrams, even though the drying was better. Why? Why didn't the better drying get better visual acuity? We'll get back to that in a couple of slides. So we did a literature review and meta-analysis looking at studies that reported intra and subretinal and sub-RPE fluid at baseline and over time, as well as visual acuity improvements, so that we could correlate the two. And what we found was actually very striking. In every study that reported intraretinal fluid and visual acuity, the intraretinal fluid was associated with poor visual acuity baseline and poor improvements in visual acuity through 1 year. Whereas those studies that discussed subretinal fluid and the visual acuity baseline as well as improvements, they were split. Half of them showed that it didn't really matter if the subretinal fluid there, meaning it was an average. Half of them showed that the subretinal fluid was associated with better visual acuity. When you look at 2 years, we found exactly the same. Fewer trials, but every trial that reported intraretinal fluid showed that it was contrary to visual acuity improvements, and half of those that reported subretinal fluid showed improvement, half showed that it was about average. So we see this recurrent theme of intra versus subretinal fluid. And when we look at our patients with neovascular AMD, we shouldn't just look at thickness of the retina and think that we're getting successful as we get a lesser thickness. We need to look at the fluid compartments, especially intra and subretinal fluid, because that can help manage our patients and decrease the number of injections required, because we want to chase the fluid that's important, the intraretinal fluid. We want to tolerate the fluid that's not important, and that's the subretinal fluid. We go back to Hawk and Harrier. Superior drying with brolucizumab, same visual acuity. Why? Well, when you look at this slide, I've outlined, whoops, right there. Look at the top of the slide. On the left, in green is subretinal fluid. And you can see that the eyes with aflibercept had more subretinal fluid over time with aflibercept compared to brolucizumab. So brolucizumab dries subretinal fluid better. But when you look at intraretinal fluid in red, the intraretinal fluid drying was exactly the same between brolucizumab and aflibercept. And that's where the visual acuity matters, is what happens to the intraretinal fluid. Those two drugs work the same. So when brolucizumab dries the retina, it does, but most of the drying, the excessive drying, is subretinal. It's not intraretinal. Well, Genentech then developed faricimab, and originally they were looking at faricimab as a superiority agent. And they actually looked at trying to get superior results in phase 2, the Avenue trial, but they found they couldn't get them. It would not give them superior visual acuity results. And so what they did was, rather than go into phase 3 with a superiority trial, which is very hard to achieve, they pivoted and they went for non-inferiority and durability. They really wanted now a durable or long-acting agent. And faricimab certainly has signals that it works well. They also discussed drying. And you'll hear a lot of talk that faricimab dries the retina better. Well, does it? But if you look at the results out of Kenai and Lucerne, and then you look at the drawing on the bottom, out to you two different periods. On the left in each of those graphs is what happens after the first 4 or injections, up till about week 16. There we go. So if you look at the subfield thickness graphs, I put these green boxes to divide them into two different sections. What happens early on? Early on, the faricimab eyes are drier than the aflibercept eyes. You see that in both trials. But once you hit week 20 or so, the drying effect is exactly the same. In fact, they crisscross, depending on which group gets an injection at which time. And when you end up at the far end of this, there's actually a methodological advantage to the faricimab arms because they're only evaluated 1 week after the last injection, whereas the aflibercept arms are evaluated 2 weeks. So when you look anything from week 20 on, the drying is the same between these two drugs. And the only advantage to faricimab in drying appears to be at the beginning, meaning through week 16. But ultimately, what happens? The visual acuities end up being the same at the end point. So the difference in that early drying did not seem to correlate with the difference in visual acuity over time. And so how do we manage this? Well, it's important, again, look not just at central subfield thickness and is it dry completely. If you do injections and all the fluid goes away, great. Now you know you have disease control and you can start your treat and extend very quickly. But if you've gotten rid of intraretinal fluid, your subretinal fluid has diminished but is stable, that's very reasonable to tolerate and go ahead and treat and extend on that. I generally don't stop therapy in those eyes if I can help it, because I worry there's a little bit of disease activity that may be contributing to the subretinal fluid. So I'll extend to a point and then usually stop, but I then usually stop my extension, but I don't usually discontinue therapy. But knowing that difference, that we can achieve and maintain gains by not tolerating intraretinal fluid, but tolerating subretinal fluid, should be one of the goals that we have with our therapy. We have a lot of data, both prospective and retrospective, that points out that important difference in the fluid compartment. So let me show you a couple of clinical cases. These are my cases that have had good and mixed and bad results, but some of the results have surprised me as we talk about the different drugs and their ability to manage disease. This first patient was a 75-year-old ex-US Marine, and he comes in with metamorphopsia and decreased vision in the right eye. Surprisingly, his vision's only 20/40, so it's not too bad, but you can see sub-RPE fluid, subretinal fluid, intraretinal fluid. So he's got fluid in all three compartments. We said from the beginning, what's my goal? My goal is to get rid of this, to minimize but stabilize that, and then wherever that goes, I don't really care as long as it doesn't get worse. So fluorescein angiogram shows he has probably a type 1 neovascular membrane, as we often do in the United States, especially a few years ago, started him on bevacizumab and did 3-monthly injections. Well, what happened? The PED detachment is getting larger. The visual acuity is getting worse. And so we talk about now the concept of switching, and there's no agreed upon criteria for switching. We'll talk about some that generally people think about, but nobody has unanimous agreement. However, if I'm injecting a patient 3 times and they're getting worse, then I'm truly thinking of changing therapy because I don't like the direction this is going with visual acuity and with the RPE detachment. So I switched the patient to aflibercept 2 milligrams. Here the patient is after 3 monthly injections. You can see that now we've gotten rid of fluid in all the compartments. So that tells me I've got the disease under very good control. And at this point, I can go ahead and I can start extending. And I'm generally pretty conservative, but I extended by 2-week intervals. I got the patient up to about every Q16 weeks, and the patient looked like this with 20/25. We were both pretty happy with this. After 3 years of this, I actually said to him, maybe we don't need to treat this anymore. Maybe we can stop and watch. So decided to stop the therapy, and that was my mistake. So I was out of the clinic, and he comes in complaining of metamorphopsia in this eye, and you can see a little bit of intraretinal fluid now is starting to come back in the papillomacular bundle. He saw one of my partners, and partner went ahead and gave him brolucizumab. And patient comes back a couple weeks later, and he has a subretinal hemorrhage and all this fluid. So obviously, very poor outcome at this point. So did a intravitreal TPA SF6 gas, face down positioning, try to move the blood. As you can see, relatively unsuccessful, and you end up with a disc-deformed scar at the end of 1 year. Not uncommon with large hemorrhages. So kind of mistake, try to learn from the mistake. 6 months later, he comes in complaining of decreased vision in the left eye. And now he has this in the left eye, this multi-lobed pigment epithelial attachment, subretinal fluid, a little bit of retinal thickening. And so he's obviously now got a type 1 choroidal neovascular membrane in his good eye, his only eye. And so I start him on a aflibercept Q4 to 6 weeks. 9 months later, he looks like this. Not bad. He's stable at 20/40. He looks like this. He has subretinal fluid that's stable, and he has pigment epithelial detachments that are not getting bigger. So this is an eye that I'm going to tolerate the subretinal fluid. And in the 20/40 eye, he's very functional. So this is an eye I'm going to treat forever. And that's my plan, is to treat him roughly every 6 weeks or so forever and not discontinue therapy in this eye. So this begs the question, when do we switch drugs? And then if you will go back 20 years ago when we had anti-VEGF therapy that came to us, and for those of us who were around 20 years ago, our decisions were easy, weren't they? You take the patient and you treat them, and you treat them monthly. And then we started learning about PRN, and then we got treat and extend, but we only had one drug. So it was a really easy decision. And the only switches we could make was frequency. We couldn't switch drugs, we switched frequencies. So now, of course, we've got this list, and it's going to be a growing list. And of course, you know, the one thing we didn't put on here is biosimilars, but we've got the biosimilars to work with too. So we've got a lot of decision-making in patients that we think have inadequate response, not a failure necessarily, but an inadequate response. Those are the patients to consider, do we change something? And because the challenges here are, there are a lot of individual differences in response to anti-VEGF drugs. Patient may respond really well to aflibercept 2 milligrams, but not well to brolucizumab. Now, you know, is that expected? Well, we should expect the variability. We shouldn't expect it based upon making it a prediction based upon the drug change, but we should say that there's a variability. You might get at the top end and patients do really well, but when you switch, you might get the really poor result, because that's where the standard deviation comes in with respect to fluid management as well as visual acuity. So always keep that in mind, that switching is like a poker game. When you switch, you play a very high stake. The high stake is you might get better, you might get worse. The average is you're not going to change very much, but you're hoping for that better. If you don't get the better, what do? Switch back. Because many of the patients will re-respond going back to the first drug. And I'll show you examples of that as we go forward. We talked about things like primary response, secondary response. How does that come into switching? Well, many physicians will think that 3 months is sufficient to assess a patient response to think of, well, should we switch now? Some people say 6 months. There's no agreed upon number, but those are commonly used numbers that you can use in your practice to think this is a reasonable time to look at the patients. And I'll go through several examples of these. So if we're going to talk about switching, we should probably have a framework for what constitutes a good response to anti-VEGF therapy, what constitutes a poor response. I do not expect everybody to memorize this slide. There's too much on here, but 2 things are very easy to memorize. One is a good response. More than 75% reduction of excess fluid and improvement in 5 letters from baseline. Those are easy numbers to remember. The other is a poor response. 5-letter loss and no improvement in fluid. So if you memorize those 2, now everything else is in between. And everything else is in between are clearly eyes that could be switched. These probably should be switched. And unless we're looking at extending durability or something, these eyes are pretty very happy and are doing well. So that's where we come down to this. The patients with a good response, just be happy we've got that and continue therapy. That's generally the tact I take. Those who have no response or the poor response are those that I'm going to actually try to switch. And generally, I'm going to switch them fairly early, somewhere between 3 and 6 months. So is switching with new drugs hope or is it hype? And let me give you some examples here from the literature and then examples on my clinic. This came out of Japan, and this series of patients with neovascular AMD who were on aflibercept with incomplete response, they were switched to faricimab. Well, what happened was 60% of those ultimately discontinued faricimab therapy. 73% switched back to faricimab. So a lot of these patients do not get an improved response when there is a switch to what we think might be in a drug that has a better drying effect at the beginning. So keep that in mind. Here's another one out of Japan where patients were treated more frequently than every 8 weeks. And the goal with switching to faricimab was try to extend that and go beyond 8 weeks. But what they found was at the end of this, more than 70% still were treated less than 8 weeks with faricimab. So the majority of patients failed with the primary goal, which was to extend therapy. This study actually looked at patients treated with aflibercept and faricimab at baseline and found that there was a significant difference in a head-to-head trial, again, coming out of Japan. And finally, this study from Bailey et al. Out of the UK looked at patients with diabetic macular edema that they switched from aflibercept to faricimab. And you notice that the improvements in visual acuity are very modest, less than 1 letter on average. That's even after 4 injections. And furthermore, though nearly half of these patients were on intervals of less than 8 weeks, they were not able to extend the patients beyond 8 weeks. So switching as an average doesn't work very well. And that's why we have to individualize our therapy. And finally, this study out of Moorfields, Dr. Siva Prasad was one of the authors, showed that faricimab and aflibercept had short-term anatomic and functional gains that were very similar to each other. So that sort of fits with what I showed you from Tanai and Lucerne, that though there are some differences with respect to initial drying, ultimately the visual acuity results and the drying effects really tend to equilibrate once you get past 20 weeks. So here's a clinical case of mine. This patient with diabetic macular edema. You can see that she's got bilateral edema, 20/50 here in the right eye, 20/70 here in the left eye. And I'm a big proponent of the DRCR-NET protocol T. And so I generally start all my patients 20/50 or worse with aflibercept because the results really showed superiority to the other first-generation agents. So I started her on monthly aflibercept, treated her, and here she is after, this is now 6 injections. The right eye is 20/30, the left eye is 20/50. And I think everybody would look at that and say, it's a good response. It's not a perfect response, but it's a good response. And she's improved fairly nicely visual acuity, and she's not quite, but she's nearly dry. So in the United States, we have a very different medical environment than here. And one of the differences is companies are able to advertise their drugs on TV. So Pishi comes in and says, I've seen these new drugs on TV, and I've had this response, but I'd like to switch and try one of the new drugs. And the new drugs were brolucizumab and faricimab that were being advertised. So I said, we can, because both those drugs look like they're going to do well and they have good profiles. So I said, if we want to do this, let's do the following. Let's switch one of your eyes to brolucizumab. Let's switch the other eye to faricimab, and let's see what happens. So here she was after the last aflibercept. Here's the brolucizumab eye. Here is the faricimab eye. What happened was she actually got worse in both eyes with monthly therapy, which really surprised me. I didn't expect one, much less both eyes, to get worse with switching. But it points out that interpatient variability of how they respond to drugs. And there's going to be a large standard deviation. You may get a really good response. You may get a bad response. Remember, if you get a bad response, switch back. And so I did that with her. I switched back again to aflibercept 2 milligrams. And we ended up pretty close to where we started, 20/30 and 20/50. In this eye with diabetic macular edema. So always be prepared to switch back when needed. This patient was another diabetic, 81-year-old lady, followed by me for many years. I had even done a modified grid, which I don't do often for diabetes, but I did a modified grid in the past. She originally started on bevacizumab. Now she's on aflibercept 2 milligrams. And you can see she's still got some persistent thickening in the fovea. And that's despite treatment every 4 to 6 weeks. And then 3 years later, she's looking like this at 2050. 6 months later, she looks like this at 2040. So she's clearly getting worse with near monthly aflibercept 2 milligrams. So now I'm thinking, can I switch her and try to reverse this pattern? So I went ahead and switched her to faricimab. And you look at the maps up here as well as the thickness pattern. Here she is after 1 injection, after 2 faricimab, and here she is after 3. So once again, she's gotten considerably worse with monthly faricimab times 3. And now I'm thinking, what can I do at this point? Well, so switching back is one option. There are other options as well. But remember, switching is a high stakes game. On average, you don't change much, but you're looking for, in American, it's the home run. In India, it's what, the wicket? Would that be the equivalent? You're looking to get that as your good result, but you might not. You might get the bad result. And if so, consider switching back. This came from Peter Kaiser from Cleveland Clinic. And Peter and I were sitting next to each other in a meeting. And Peter said initially, they looked at their faricimab data at a Cleveland Clinic on switching patients. Most of them had been switched from aflibercept 2 milligrams. And he said a third of them got better, a third of them stayed the same, and a third of them got worse. And for those patients who got worse, they switched them back to aflibercept, and the patients got better again. So again, pointing to that variability and the need to consider switching back if you get a result you don't like. The Truckee study was an early phase 4 or post-approval study looking at patients receiving faricimab. About 80% of these were pre-treated. The pre-treated eyes had a visual acuity improvement of about 1 to 2 letters. I think switching studies are important, but as a journal editor, I hate them because there are very few switching studies that have good methodology because you don't know, you've got nothing that's standardized before the patient switched, and you have no standardized interval between the last injection of the first drug and the first injection of the new drug, which is critical when you're looking at improvements in visual acuity and subretinal thickness. I think in ophthalmology, we've only had 2 really good switching studies, and neither of them is macular degeneration. The only good ones, I think, are DRC-ARNET protocol AC, where they took diabetic eyes and they treated them with bevacizumab or with aflibercept, and those eyes that didn't respond well to bevacizumab were switched to bevacizumab, or excuse me, to aflibercept. And what they found over the course of 2 years is the visual acuity of the 2 groups were exactly the same. So switching those eyes, beginning at 3 months, didn't disadvantage where they ended up at 2 years. And switching from bevacizumab to aflibercept does make sense when looked at prospectively. The other one is the SCORE2 trial. And SCORE2 was looking at patients with vein occlusions. And in SCORE2, they randomized patients at baseline to receive bevacizumab or aflibercept 2 milligrams. They treated them for 6 months. And then they looked at results at 6 months, and they found those eyes that didn't do very well. And the bevacizumab eyes that didn't do well, they switched to aflibercept. And on average, they improved about 9.9 letters over the next 6 months. The aflibercept eyes, they switched to Ozurdex, and those eyes improved about 2 letters over the course of 6 months. So very little improvement. So those are the 2 switching studies that I think make a lot of sense, and it kind of sets the stage for what works. I think it works much better in retinal vascular disease than it does in macular degeneration. So here is a interesting switching study. And I want you to read the title. This is evaluating the effects of switching anti-VEGF drugs for macular degeneration and diabetic macular edema. And the authors are Rick Ferris from the DRC-ARNET and Dan Martin from CAT. What they did was they took the data from the DRC-ARNET protocol I trial and from CAT, and they applied switching criteria. Now, they talked about the effects of switching. Well, those of you who know what the studies were about, there was no switching in those studies. It was all the same drug. But what they did was they said, let's evaluate those eyes at 3 months and 6 months, which are standard switching interval decision-making points, and say, what happened after the 3-month and the 6-month mark? Did they get better? Did they get worse? Or did they just stay the same? even though they were poor responders at the beginning. And what they found was after 3 and 6 months, both the diabetic as well as the macular degeneration eyes improved between 3 and 5 letters after they would have been switched. And so it says that many of the effects of switching that are reported to be positive are simply because patients are late responders, and it's not because they're non-responders. And so this is a very interesting trial that points to persistence. And even going beyond the classic 3-month and 6-month switching points is not an unreasonable thing to do, because you'll identify eyes that respond late as opposed to non-responding at all. So can we target other pathways? Certainly, pathways are an important part of the treatment of choroidal neovascular diseases. Now, we know that VEGF-A, working through receptor 2, is the primary driver of all of our choroidal vascular diseases. But aflibercept also binds to placental growth factor, which has similar downstream effects as VEGF does. And ranibizumab, or excuse me, faricimab, of course, has the anti-Ang2 arm. And we'll talk a little bit about that in detail as to what the positive or the negative effects of that might be. So what's interesting is that Ang2 actually was discovered by the scientists at Regeneron. And Regeneron then went very quickly to try to do combination therapy of VEGF inhibition and Ang2 inhibition, because they developed a drug called nesvacumab. And they did nesvacumab in combination with aflibercept, and they compared it to aflibercept monotherapy. And what they found in AMD and DME in phase 2 trials was it seemed to be exactly the same. They couldn't figure out a superiority, so they stopped Ang2 binding as a strategy. Now, Genentech, on the other hand, picked up on Ang2, and they said, well, we're going to do this, but we're going to make one drug, not 2 drugs. And so they, of course, then created faricimab as a single agent to bind to both VEGF as well as Ang2. And what they found was that faricimab certainly works very well for AMD as well as DME, but there was no evidence of superiority. And as I showed you in the previous slide, there seems to be an advantage in drying for the first 16 weeks for AMD, and then the advantage goes away. So they couldn't do superiority, so they switched to durability or length of time between injections. And faricimab does seem to have durability signals. So why does it have durability signals? Well, the Ang2 binding might be one, but also it's a larger molecule, so it stays in the eye longer, so it has a longer half-life. Secondly, it's a larger molar dose than aflibercept. So you've got three major differences between faricimab and aflibercept, and we don't know how to determine which is the important one. So all we can do is accept the molecule for what it is. What's interesting is when the FDA looked at faricimab, they approved it because it had good results and it had a good safety profile. But what they said was the contribution of Ang2 inhibition has yet to be established. So they couldn't actually say the Ang2 did anything. They said this is what the molecule does, but we don't know that Ang2 actually contributes to that or not. I was at a meeting in 2023 and spoke with a Genentech scientist at one of the breaks, and he looked at me and he smiled and he said, we still have no idea if Ang2 binding actually does anything. That's coming from the people who made the molecule. So when you look at rabbit models, what we find is from rabbit models and other preclinical models is that Ang2 levels seem to go up and down with VEGF levels. When VEGF level goes up, Ang2 goes up, and VEGF may be a stimulant of Ang2 synthesis. If you treat VEGF and the VEGF levels come down, the Ang2 levels come down, regardless of whether you treat the Ang2 itself. So there's a lot of interplay between the two, and that the Ang2 concentrations likely are VEGF dependent rather than being dependent on any specific binding. So Regeneron learned this, and as a result, what the Regeneron decided to do was not pursue the Ang2 binding. So we go back to the Avenue 2 trial. Remember, that was the trial I said before, faricimab trying to be a superiority over ranibizumab monotherapy, and it failed to show superiority. What they also did in that trial was they measured Ang2 concentrations at baseline and 28 days later. And you would expect that in the faricimab arms, the Ang-2 concentrations would fall because faricimab should bind Ang-2 and the Ang-2 goes away. So what they found, though, was a little bit more surprising than that. And then when you break down the 5 different cohorts and you look at Ang-2 at baseline, that's the gray, Ang-2 at 28 days, that's the other colored ones down here, you find that in all the faricimab groups, the Ang-2 levels fell dramatically after faricimab. But in the ranibizumab arm only, the Ang-2 fell even more. And so you can see here that the Ang-2 fell dramatically, and that was not with Ang-2 binding. That was only with VEGF binding. So it speaks to this interaction that VEGF may be the primary driver of Ang-2, both in terms of stimulating and in terms of turning off Ang-2 production in the eye. And therefore, it begs the question of whether Ang-2 does anything. Faricimab is a good molecule, but we don't know that Ang-2 is a part of that actually makes it better. So we do know that VEGF is the primary driver. And of course, now I'm speaking on a topic that the people in this room know better than I do. It's biosimilars, because you've had biosimilar experience here far longer than we have. And I know at this point in time, you have one aflibercept biosimilar. We do as well. Ours is by Amgen. I think yours is by an Indian company. And so we talk about the biosimilars and sort of the positives and the negatives of biosimilars. You know, what's the positive? Well, the positive should be to drive down cost. What's interesting in the United States is it's driven down cost a little bit, but currently our aflibercept biosimilar is more expensive than Eylea. Figure that one out. Exactly. So, and the cost has dropped, about 10%, and it's more expensive. So I don't quite understand that. We call these biosimilars, and the reason for that is it differs from generics. Generics are we're driven from small molecules, 300 to 400 Daltons. You know, you make the drugs in a beaker, basically, or in a big flask, and you use standard chemistry. Biologics are very similar. You need to use human cells. You need to put together multiple chains in different ways. You need to glycosylate them. You need to be very cognizant of what's in the fluid so that you have drug stability. So all those differences. So biologics are never exactly the same as the originators. And one of the reasons that they're not exactly the same is the glycosylation. So the glucose, which is bound on here as a way of causing stabilization of the drug, less immunogenicity, and durability. All of those things the glycosylation contributes to. But what the biologics don't have is a roadmap to work with the glycosylation, and consequently the glycosylation in biosimilars is different than the original drugs. And what that means is we worry about safety. And I know you had a safety issue with one of the batches of the biologic here. We've had similar things come out of the US. And so in any drug, we always have to do pharmacovigilance, which basically means post-approval analyses. You found that here with respect to the aflibercept biosimilar. We found that with brolucizumab, because when you looked at the brolucizumab inflammation data from the phase 3 trial, it was higher than aflibercept, but the FDA didn't think it was so high to prevent approval of the drug. And only in the post-approval period, when occlusive vasculitis began to surface in the United States, did people take notice, and then they started a very intense pharmacovigilance analysis to learn exactly what the incidence of inflammation, retinal vasculitis, and occlusive vasculitis was. And the current data that came out of brolucizumab in the United States was about 1 in 700 brolucizumab patients has inflammation, or patients, 1 in 700 injections has inflammation, and about 30% of those are occlusive vasculitis. And as you know, with occlusive vasculitis, as it involves the macula, you've lost vision permanently. I spoke with a group in Europe, and they say we use brolucizumab, and then we treat them very aggressively if they have inflammation, and we've had good results. Well, 70% of them are going to have good results. 30% of them don't have. And there are many people here that are uveitis specialists, and I would say to you, how many patients with occlusive vasculitis from uveitis ever get return of vision or get revascularization? I think the answer is 0. Once you've had occlusive vasculitis, you don't make it better. So in summary, We need to be a little careful with the biosimilars. Hopefully they will drive down costs. That's the goal, but we're not sure that happens. And certainly in the US, that's not the case. Are there any strategies we can do to make these drugs better or to make them more durable? Because every time we change or alter a drug with technology, we run the risk of complications. We run the risk of putting adverse events into play or of decreasing their effectiveness. Abisapar was a drug that was put out by Alcon, and it failed its phase 3 because it had too much inflammation because it was pegylated. The current complement inhibitors are pegylated, meaning you have polyethylene glycol bound to a very small drug to extend its half-life. But that's pro-inflammatory, and we know that there are vasculitis cases with the complement inhibitors as well. Kodiak is a company that produces an aflibercept-like molecule, puts conjugates on them to make it really big. So you put it in the eye, and a really big drug lasts a long time. But what happens is a really big drug doesn't get into the retina. And they found that they failed their phase 3 trials. So, and then the Susvimo, the implant from Genentech, had to be taken off the market because of this septum. So every time you add a technological layer to try to extend things, you run the risk of causing unintended adverse consequences. So how can we make drugs better? Well, can we make them so that they bind better? Because if they bind better, then they'll work at a lower concentration and inhibit VEGF down here at this concentration, thereby extending the time. And that's a very admirable goal, is to make a drug that binds better or stronger. The problem is we've got the strongest binder already, which is aflibercept, and no clinical or experimental molecule has been shown to have a higher binding affinity than aflibercept. So this strategy is probably not going to work for subsequent drugs. We can get good binders, but we're not going to get better binders. So what the drug companies have done, and you can see this with brolucizumab and even with faricimab, is they're increasing the molar dose of the drug given in the eye. More drug in the eye is going to last longer before the concentration of the drug falls down below this threshold needed for VEGF inhibition. And if you look at this, on a cartoon kind of fashion, higher drug concentration here, it's going to remain higher at every point in time. And when this concentration fails to inhibit VEGF, this is still going to be high enough that it's going to allow for a delta of time for longer durability. And that's the strategy behind the newer drugs. And when you look at the new drugs, brolucizumab, faricimab, aflibercept, 8 milligrams, they've all got, by and large, the same strategy. It is a good molecule with a higher dose for greater durability. And so the concept, and this has been thrown out by Bayer frequently, is what's called shifting the curve. And it's based on the fact that many of our patients fall into one of two different time frames with respect to frequency of injections. Many of them are here down at 4 to 8 weeks. Other ones are up here at around 10 weeks in terms of how frequently they need the injections. And what we hope with the new drug, with the aflibercept 8 milligram in particular, is you're going to end up taking the patients who need very frequent injections and decreasing the number of them, so you put them here into longer durability. You're not going to take a patient who requires injection every 4 weeks and turn them into 20 weeks. That's not going to happen. But you might turn them from 4 to 6. So thereby decreasing the number of injections by almost by a third. The second thing is we take these patients that are doing well, way out here, and say maybe we can do even better. If we're stuck at 10 weeks, maybe we can go to 15 by using the quadruple dose or the high dose of aflibercept 8 milligrams. And so the 8 milligram is aiming to address unmet needs. And those unmet needs are durability, decreasing the frequency that patients come back to our practices. I know in my practice right now, I'm getting swamped because I have 2 other retina physicians that have just recently resigned or retired. So I'm doing the work of 3, which keeps me up at night. And so anything we can do to decrease that frequency is going to be a good thing. The other thing about the newer drugs, and 8 milligrams is no exception to this, is when you put a very high dose into the eye, you get a higher dose at the cellular level. And what that does is it shifts the equilibrium binding curve. So you drop the free VEGF concentration by a factor of 4. And as you drop the free VEGF concentration, you're able to treat some of those very difficult to treat eyes that the 2 milligram standard dose is not able to get to. And that's why when we look at photon and pulsar data, we can see that there's a better drying effect with the aflibercept 8 milligrams after each of the first 3 injections compared to what we get with 2 milligrams. So final thing is global trends, and the global trends really have been very favorable to aflibercept. It's been a good molecule, excellent efficacy, durability, and most important, safety data. And so when you ask physicians, US internationally, what is your drug of choice if no payer access restrictions? Aflibercept is the drug of choice. And especially for those patients with DME of worse than 20/40 vision, 20/50 or worse, that far and away based on protocol T, aflibercept has been the drug of choice. So it's been the global leader, excellent safety, efficacy, durability profile, and the 8 milligram, which I think you will be seeing hopefully early next year. I think you'll be very impressed with the drug in terms of matching the safety profile of 2 milligrams and showing us increased efficacy both on the short end as well as the durability. So thank you very much. I appreciate the opportunity.
Thank you. It's an excellent. I mean, the way you have described it, I think most of the questions has already been answered. But still, you have very well put that there are 3 levels of fluid there. So the most toxic is intraretinal fluid, followed by the neutral is sub-RPE, and probably the more helpful is the subretinal fluid. So in your practice, like you have shown that case very nicely, where there was a minimal amount of the intraretinal fluid where you have stopped the treatment and it has rebounded back. So at what point of time you stop, even in presence of intraretinal fluid, you stop and you decide to again come back, or you increase the frequency of the patient visit?
Yeah. So if there's persistent intraretinal fluid, I'll never stop injections in those patients. Now, that has to be differentiated from retinal degeneration, because retinal degeneration also occurs in eyes with macular degeneration. Glenn Jaffe had pointed this out. Retinal degeneration has very irregular shapes within the inner retina and tends not to fluctuate. Intraretinal fluid will fluctuate based on treatment and generally is ovoid or spherical. So first of all, differentiate between the two. If there's persistent intraretinal fluid, I'll inject them monthly until I think I've gotten it as good as I can, usually after 6 monthly injections or so. And if at that point there's still some persistent intraretinal fluid, I'll slowly begin to extend, because not all intraretinal fluid goes away. And sometimes we can tolerate it, but we tolerate it very carefully. But I'll never stop intraretinal fluid, the injections, if there's persistent intraretinal fluid. But I'll tolerate some, and I'll slowly extend after about 6 injections.
So as far as the intraretinal fluid is there, you will continue the treatment.
Yes.
So as you mentioned, the subretinal fluid, little bit can be tolerated.
Yes.
So at what point of time do you think this persistent fluid can be tolerated and we can extend the treatment?
Yeah, so subretinal fluid, and that's what your question is, and that's a difficult one that I struggle with. I tend to be conservative with the way I treat, which means I tend to treat more and extend slower rather than many other people do, or rather than some of the guidelines suggest. So if there's persistent subretinal fluid, if it's subfoveal, I'll usually get them out to around 16 weeks, but I'll continue. If it's extrafoveal, then I may stop and watch. But if it's subfoveal, I keep thinking there's active neovascular disease centrally, and I don't want to withdraw my therapy. But extrafoveal, I think you can discontinue after 16 weeks.
As far as this 8 milligram is concerned, we have not come across this molecule. So what are the cases, like, is it only the durability which increases with this high molar dose of aflibercept, or you feel the efficacy is also better compared to 2 milligram of aflibercept?
Right. So that's a really important question, because in the trials, when we talk about pulsar, photon, and then quasar, which is the vein occlusion trial, it was all done with the premise that the efficacy is going to be about the same, and efficacy as defined as visual acuity changes. but that the durability would be longer. So that was the premise of the trial. So the trials were structured to look at durability and extend. And really the numbers were very good when you had patients who very quickly after loading doses were extended to 12 and 16 weeks and maintained on that. And then the 2 milligram cohorts at the end of 2 years were then switched to 8 milligrams and had rapid further drying after the first dose. So you see efficacy is there, that you can get better drying after 2 years with 1 dose of 8 milligrams than you ever got with 2 milligrams. The other thing about the efficacy issues are when you look at the drying effects early on, is that you get greater drying in the diabetic patients who had the thickest maculas. They dried better at every time point in the after first 3 injections with 8 milligrams than they do with 2 milligrams. So it dried better. And when you look at the persistence of fluid in macular degeneration, at every time point in the first year, you had more dry retinas with 8 milligrams than you had with 2 milligrams. So the efficacy is there with respect to the drying. Is the efficacy there with respect to visual acuity? And then it has to be individualized, because as a cohort, it's not there. On a patient-by-patient basis, it can be there. And so you just have to sort them out and go through it. You know, why is that the case? Well, it goes back to, and I don't have a slide here, but it goes back to chemistry. And as we did equilibrium chemistry, as we all studied in college, what we find was that, you know, the concentration of the reagents dictate the concentration of reactants. And as you increase one reagent, and then at equilibrium, the concentration of the other reagent goes way down, because you keep the equilibrium constant. And so what happens by quadrupling the dose is you drop the dose of VEGF, or drop the remaining VEGF by at least a factor of 4. And so by dropping the VEGF unbound in the tissue, there's always unbound VEGF, that you decrease the VEGF effects, hence you decrease the leakage. I do have a couple of cases on 8 milligram, and it may be instructive. Oops. Back on my slides. Thank you. Yeah, there we go. So you've seen this case. This was the lady that I treated for 3 years and then switched to 3 faricimab, and she got worse. And this at the top is after her 3rd faricimab. So then I said, well, I may have to switch. So what did I do? Well, I actually had 8 milligrams available at this point. So I gave her 8 milligrams. And here she is, first dose after 8 milligrams. Vision's 20/40. You can see that she's substantially drier, not dry, but drier. 4 weeks again. Now she's beginning to get what looks like a more normal macula. And then we continue 4 weeks, we go to 5. Eventually we get out to about 7, and she keeps her vision to about 20/40. At this time, we were actually in an era where we couldn't use aflibercept 8 milligrams every 4 weeks. The FDA didn't allow it. They do now, but they didn't then. So we had to switch to 7 weeks. And so we keep her on 7 weeks, and she actually looks pretty good. And so now I'm back to a stable phase at 7 weeks that I was never able to get to with with faricimab, 2 milligrams, or bevacizumab. So it worked really well. Here is a patient with neovascular AMD, and he was treated with aflibercept 2 milligrams up north, has moved down to Florida, so I've taken over his care. And he always has this subretinal fluid. And this is with aflibercept 2 milligrams, even scheduling him on an every 4 to 6 week basis. I can't get rid of it. Now, you know, as you've heard me talk, subretinal fluid can generally be tolerated. But you always have this thought in the back of your mind, will the vision get better if I get rid of it? Because I've never gotten rid of this. I have a new drug. Let me try it. So I gave him aflibercept 8 milligrams. Here's the first dose. Here's after the second dose. For the very first time, I've gotten him dry. Did it make a difference? Well, his vision now is 67 letters. He started at 63. So I've improved him by almost a line of vision. And then always just this little bit of fluctuation, but most of the time the outer retina looks pretty good. And he stays dry. And now I'm treating him at 8 weeks, and then I would start to extend out towards 16. So you do get the increasing drying effect. Sometimes you get surprised, and sometimes you get better vision out of it. So yes, we can tolerate subretinal fluid, but only when it's not going to make the vision better. Here I got surprised. And you can see, again, all this, you never get rid of it entirely, but there is a little bit of fluctuation. But the visual acuity stays, again, about 4 letters better than when we started. Here's a patient who has new onset metamorphopsia in vision, and he's got a type 1 choroidal neovascular membrane. So I give him one injection, and you can look at the top, compare that to the left, and there he's after 4 weeks after the first injection. And he looks almost normal. Now, I would normally think of injecting him again every 4 weeks. In this case, he actually came back 7 weeks. And you can see that morphologically, he's looking better. He's thinner. Look at his vision. Went from 20/60 to 20/80. And I don't get too concerned if the morphology is improving and the vision is dropping a little on one visit. I don't get too worried. I just think that the patient and the technician didn't play well that day. So I say, okay, I'm going to continue doing what I'm doing. So now I get another 7 weeks. Now he's 20/30. And now we go to 9, 11, out to 15. And you can see he's 20/30 and doing very well. So we're able to extend him pretty quickly. I don't believe that 3 loading doses is necessary in macular degeneration. I think you load until you've controlled the disease. Once the disease is controlled, then you extend. But that could be after 1 injection. It might be after 3. It might be after 6. Dan Martin, who ran CAT, says in his opinion, 1 is a loading dose in macular degeneration. So 3 is sort of an arbitrary number that's not backed up by science. Disease control is backed up by science, not 3 as an arbitrary number. And then this patient comes in, 76-year-old, and he's got subretinal hemorrhage. And you can see on the OCT that he's got a significant amount of subretinal fluid centrally with a vision of 20/50 minus. So when you look at the OCTA, it's interesting. On the upper right, you can see this leash of blood vessels that's coming from the peripapillary area and coming into the superior macula extrafoveally. So it's not classic neovascularization, it's really peripapillary with a growth that's coming up towards here. And then this nest of blood vessels that this is nourishing. So that's why you see almost this double lobed thickening here because of the subretinal fluid, and then the thickening here related to localized edema based on that. So here's 1 injection, and he's almost completely dry at 20/40. You can still see some thickening up in this area, but that's extrafoveal, so I'm not as worried about that. Second injection, he's 20/50 minus, but completely dry. Still a little bit of thickening up here. Third injection at 7-week interval, now everything is completely dry. And now we go up to 9 weeks and we go forward and completely dries him up. So very nice drying effect with the 8 milligrams. And final case, 73-year-old physician comes in, macular degeneration for a second opinion, says he's been treated with previous anti-VEGF agents. He's never gotten really dry through 4 weeks. He says he gets better with the injections, but at about 3.5 weeks, the vision starts to taper off. And he notices the effect. So he's 20/60 minus. His last injection was 5 weeks ago, and he looks like this. And you can see intra-subretinal fluid, some SHRM here. And there's the neovascular complex. So here he is 4 weeks after the first 8 milligram injection. And then another 4 weeks, and you can see he's really improved the anatomy very nicely. And what he now tells me is the vision was never this good with previous treatment, and it doesn't diminish as he approaches time for the next injection. So the durability is greater than we saw in the previous agents.
So to give this 8 milligram as an reserve dose where it is not working with the 2 milligram?
Yeah, so I think when we get new drugs, that's how many of us approach that, is we say, well, I'm going to start using it on those eyes that don't respond well to other drugs. But as I've kind of emphasized, switching is not really a great tool in our armamentarium. We try it. It's a it's a high risk game of good results, bad results. This drug, 8 milligram, was actually designed to be a primary therapy. And when you look at the patients that were enrolled in the phase 3 trials, every macular degeneration patient was treatment naive. 56% of the diabetes patients were treatment naive, and 100% of the vein occlusion patients were treatment naive. So it was really brought in as a primary agent. It works well when we look at switching, but it was really designed as a primary agent. So I use it for both.
One question. In one of your slide, you show the good response and poor response, 5 letters. After how many injection, one can say that the patient is poorly responsive?
Yeah. So if it's stable and poor, well, actually, take it back. Poor, by definition, is 5-letter loss. Yeah. So if it's after 3 and it's a 5-letter loss, I'll switch at that point. If it's if it's an incomplete response of maybe minimal change in vision or no change in vision, I might go to 6. But if it's a loss of vision, I'll switch after 3.
Thank you.
Can I ask something? So actually, you were talking at one point of time that you can sometimes get back to the previous injection. So whether we are removing the tachyphylaxis then, so when we are changing the drug initially, so there might have been tachyphylaxis with the first drug. So when we are going into the second drug and again coming back to the first drug, is the tachyphylaxis removed or something, or in some other ways is it working?
Yeah, so you're right. It might have been a tachyphylaxis, or many of these eyes are not necessarily tachyphylaxis, which of course is a decreased response over time, but rather is just an incomplete response from baseline. And those are the eyes that we think that when we switch them back because they failed a switch therapy, we get them back to where they were. We're not going to get them perfect, but we'll get them back to where they were. If it's tachyphylaxis, then I'm much more inclined to switch to a second agent or a third agent. Whereas if it's just an incomplete response, I may switch them back to where I started. That's the difference.
First of all, sir, thank you for coming here, and we always keep waiting for you for the next time again.
Thank you.
And I was just wondering whether pumping in a higher molar dose can cause RP, dysfunction. Have you noticed in any FA change, autofluorescence changes?
Yeah. So the answer, the way you put it is, I've not noticed that. Now, I've not seen published data to say that it looks like it increases, because you're right. Could it? And the answer is maybe. I've asked for data from Pulsar, but that's not been an analysis that's been done on a Pulsar. I wish they would do it, but they've not done that. So at this point in time, we don't know. But I've not seen it in my practice, and I don't have any published data to say one way or the other. But good question.
Thank you.
What we understand that in macular degeneration, these patients often need to have a continued treatment for a long time.
Yes.
But in our country perspective, often the patients ask us, when I'm going to get rid of these injections.
Yes.
So what answer to give to them? And another patient I'm going to just ask about. The patient had lost her vision in one eye because of massive subretinal hemorrhage following, secondary to macular degeneration. In the other eye, she was okay. She was having 6/9 vision, and gradually now I find that the vision is dropping, but there is no sign of any fluid, intraretinal fluid, but there's some irregularities in the pigment RPE and Brooks membrane, and on OCTA also we didn't find any branching vascular pattern, no sign of any CNVM.
Okay.
So what could be the strategy in such cases? Vision is dropping in the other eye, only eye.
Yeah. So the first question of yours is when to stop. What do we tell patients? So when a patient comes in, let me back up and say I have many patients who come to see me for second opinions, and they've told me, well, I still have blurred vision, and I've been told I need injections, but my doctor told me I needed 3 injections and I was done. And I go, oh boy, okay, that's the wrong message at the beginning. So when a patient comes to me and we say we're going to start injections, and then they ask me how many do I need, and my first response is, how long are you going to live? And that sort of sets the stage in their mind for this is a never-ending process. And then I follow it up and I say, the plan is to treat you for the rest of your life, but we may get lucky. And you might be one of those 20% of people where we can stop therapy after a long period of time if the disease responds well. And then I say, here's what we're going to do. We're going to give you monthly injections until the disease is under control. And I don't even specify a number, monthly injections. And then if we get it under control, we usually do, then we can extend it out. If we get you out to about 16 weeks between injections and the vision is stable and there's no fluid, we can talk about stopping and watching. And if I get to 16 weeks and the patient's dry and I say, okay, I'm not going to give you any more injections, I bring him back at 8 weeks, then I'm 12 weeks, then it's 16 weeks, and I usually follow them at 16 weeks. If they have persistent fluid in a one-eyed patient, I never stop, because I think that there's too big a risk of getting irreversible vision loss with recurrent disease in a one-eyed patient. 16, yeah. So the patient I'm not going to stop, I'll get him to 16 weeks, and I'll do it at 16. Now, your patient where you had clearly massive hemorrhage in one eye, maybe that's a PCV, that's probably what that was. And now you've got the other eye and some decreasing changes. You've got no fluid on OCT. You've got no demonstrable lesions on OCTA. And I would say it's probably not neovascular, but now maybe you've got RPE modeling, depigmentation, and do an FAF and try to look and see, is this RPE degeneration rather than neovascular disease? And I'm betting that's the case.
Great lecture, sir. I have a little question, one or two questions. In diabetic patient, we often see that after giving multiple injection, like one of your case shows there is a drying at the center of the fovea, but there are a lot of parafoveal cysts persisting. So in those cases, how long you will keep on giving injections? Because the vision may remain same throughout the number of injection you give. So that is my first question.
Yeah, I think in those, if you've got extrafoveal lesions, then you're much more, and diabetes, of course, is a much more forgiving disease than macular degeneration. So I'm much quicker and more confident in stopping therapy in a diabetic patient, of course, stopping and watching, than I am in a macular degeneration. And if I can get that patient out to 8 weeks and they're dry centrally with only a few extrafoveal cysts and their vision is decent and stable, then I'll say, we can watch you. And I sort of convert to a PRN at that point. And so I describe my own philosophy as schizophrenic, because I do treat and extend for macular degeneration, I do PRN for diabetes, but I'll watch them if they have some extrafoveal cysts that won't go away. After 8 weeks of successful treatment, I'll watch them. But I'll also say, if you've got the extrafoveal cysts, there's probably some disease that's active, and it is likely that if I stop therapy, that the treatment will come back. The other thing in a case like that, where the fovea is now dry with extrafoveal cysts, are there lesions that are amenable to laser? And would you do a fluorescein angiogram at that point and identify microaneurysms that might be laserable to try to prevent that from happening? I'm not a big proponent of macular laser in diabetic macular edema, but that would be one of the circumstances where I would consider focal therapy to persistent microaneurysms.
So this brings my next question. Where is the FFA stands to you when you investigate the patient for FFA in diabetic or CNVM?
Yeah, so the fluoresceins that I'll do is I'm much more interested in fluorescein angiography for peripheral neovascularization than I am in macular edema. Because the macular edema I'm going to treat based on the OCT, and I'll do an OCTA just because that'll tell me what the possible visual prognosis is going to be. If there's significant ischemia, then I'll tell the patient, we're going to try to get you dry, but I'm worried that the ischemia may prevent you from getting good visual acuity, and the OCTA will tell me that. I used to think that I could really identify peripheral neovascularization very well in patients with indirect ophthalmoscopy. I think most of us think that we can't. And so I'll do ultra wide field fluorescein angiography for that reason. But I tend not to do much fluorescein for diabetic macular edema because I don't know that it adds anything to what I do other than, those few circumstances where I'm going to do a focal laser.
And my third question, sir, we have seen in our practice that if we give multiple injections, say at the end of 5 years, 6 years, these CNVM patient, MNV patient tend to get geographical atrophy. Yes. So what is your take on that?
Yeah. So it's interesting because you've pointed out what might be the natural core history of the disease, of geographic atrophy, the disease with a controlled lesion. Do more injections over time give you a better result or a poorer result? And we don't have really good data after 2 years of patients that have been nicely randomized, because the trials are very expensive. And the drug companies generally don't go beyond 2 years in terms of randomizing and following patients. But there is a trend. And when you look in the literature and you see the trends of which patients lose vision over time versus which patients maintain vision, generally speaking, the more injections are given on, the better the maintenance of vision. Now, that's not to say they're not going to develop geographic atrophy or macular atrophy, but the patients with more injections do better than those with fewer injections. So I would err on the side of more injections. And I don't know that that's a complete answer to our problem, but I think at least it improves the patient's probability of maintaining vision.
Thank you. Thank you.
Yeah.
Yep.
Scarring develops, and in the case of scarring without any fluid, there's no indication of any injection.
So yeah, so you're saying that you've got a patient that either presents at baseline or after therapy and develops a disciform scar, as we would classically think of it. So a fibrotic scar down at the level of the outer retina of the RPE. And, you know, now there are some patients who have really good vision and disciform scars. I have patients that I treat with 20/40, 20/50, and those I'm going to treat. But you're right, if it's 2200 or 2400 and it's a large central scar, am I going to treat it? Generally, no, I don't. And and I tell patients, you know, if I give you injections, I don't think I'm going to make you better. And if I don't give you injections, I don't think you're likely to get worse on your own. There are exceptions to that. And some of the exceptions are patients who develop symptomatic new fluid or symptomatic hemorrhage. And when they come in and say, my vision in this eye has gotten worse, and they've got a disciform scar, I've not been treating, but they have new onset disease, I will treat them because they've noticed it and it correlates with the vision. So those are the ones I treat, but that's a minority. So yeah, go ahead. Rephrase your question.
Yeah. So what do you do for them? Like, what is your recommendation, the time duration between the CV and the injections?
So that's a really tough one. And, you know, what data do we have? Well, you know, we don't have good data to show that on average, giving anti-VEGF injections has a higher incidence of stroke. But if we go way back to the earlier ranibizumab days, and it came out of the SUSTAIN trial, I think it was, that for patients who had a previous stroke and then were treated with intravitreal anti-VEGF, their incidence of a subsequent stroke was increased by 10% over 6 months. So it seemed that patients who were predisposed to a stroke that you identify are those that have just had a stroke. And so if I have a patient who comes in and they're new onset and they just had a stroke 3 weeks ago, I'll explain that to them. And I'll say, I might increase the risk of you having another stroke. Now, if they have a new onset eye and the other eye is good, I might say, maybe we should watch this for several months, get you past the phase of your stroke, and then start treatment. So do we risk losing vision by waiting? The answer is yes, but it's not as bad as you might expect. The Phoenix trial out of China with Convercept randomized patients to initial therapy with Convercept versus observation for 3 months. And then after 3 months, they switched to Convercept from the observation group. And after a year, got right back to where the original group was. Now that's 3 months. I don't know about 6 months, but at least waiting a few months might not be bad on average. Now, if it's a one-eyed patient who's just had a stroke and the patient comes in and needs therapy, that's a very difficult conversation. And I will probably say, I'll see you back in a month and we're going to watch. And then I'll see you back in a month. And then I'll see you back in a month. And as soon as I see the vision beginning to decrease, we have a tough conversation that says, you're beginning to lose vision in your only eye. This is the only therapy we have. There's a 10% chance we might increase a risk of a stroke again. Do you want to be treated? In my estimation, they should be. but that's a patient decision that we have to have a discussion about. Now, if I've treated a patient and the patient comes back 2 weeks after I've treated them and they have a stroke, it's the same difficult conversation. If they're otherwise fine, I'll tend to watch them. If they're otherwise bad, I'll have that difficult conversation and probably watch them really carefully and then try to jump in any time there's decreasing vision.
So any particular anti-VEGF which you recommend? Like, I mean,
yeah, people will say, well, ranibizumab has a shorter intra serum half-life, that it decreases VEGF concentrations in the serum less than the other drugs do. But ranibizumab has also been a greater risk of stroke in some trials, like the VIEW trial. So the answer is, I don't think so. Even though they do change serum concentrations differently, I've not seen anything that actually says their risk of stroke is different.
Yeah, we have started getting questions from the other centers as well. So one question is that there is intraretinal fluid with fibrosis. Should we still treat them?
Yeah, so that comes back to that question of fibrosis and disciform scar. And if the vision is very good, the answer is yes, I treat them. Not many patients, of course, have subfoveal scars and good vision, but if they do, I'll treat them. If it's 2200 to 2400 and it's intraretinal fluid, I generally don't, unless they become newly symptomatic in that eye.
Yeah, so another question is that CST was a criteria for 10-year trial, central subfoveal thickness. So this cannot be the surrogate, the marker for the fluid, because it may miss the extra foveal fluid as well. So why did they so? But
yeah,
that is
although remember what CST is. CST is a 1 millimeter diameter. And so if it's extra foveal fluid, you're probably outside the 1 millimeter, and therefore that won't be measured by CST. So that's the best thing I would say, how I'd answer that.
Do pachychoroid disease. So most of the here in India, we do get 50% of those AMD patients are having underlying the PCV. So maybe in US, you get very less number of patients, but do pachychoroid disease need more powerful drying agent as it may reach the choroid better or as it is?
Yeah, so I think that, really where we need the drug to get to is really down to the level of the RPE and the RPE space. And so the fact that there's a really thick choroid underneath it probably doesn't make a difference. And so as long as you get the drug into the sub-RPE space, you're fine. And that, I think, whether it's pachychoroid or standard AMD, your penetration to that level is going to be the same. But I don't think it makes a difference.
So continuation with the previous question, the fovea is dry, but there is extra foveal fluid.
Yes.
Would you like to continue the treatment for that?
Historically, I've always been very aggressive and I've treated those, but more and more now, we have data to say that extrafoveal fluid with a dry fovea can be observed.
So I have a question for you. If a general consensus, if you talk about, you are increasing the dose from 2 milligram to 8 milligram, 4 times. So that means you are actually not changing the disease pattern treatment. You are just pushing it with the more amount of the drug. Now, if you go to the pulsar, so you have almost near about 60% of the patient who had only Q8 injections. But whereas with the 8 milligram, that is increasing more than 80% who is converted to Q16. So Q8 to Q16 is almost 8 weeks, gain you are getting. Whereas if you think of the drug per se, so 4 times means you should get the time interval of twice of the half-life duration, isn't it? 4 times means to come down to 2 milligram, it takes twice of the duration. So let's take the duration of 10 days, approximately 9 to 11, if we think about the aflibercept. So 10 into 2, so 20 days interval you can only get, whereas you are getting there 8 weeks. So how do you explain that?
You're asking a very good detailed question. So yes, and I think that was the expectation going in, that we all thought you're going to increase it by 2 half-lives. And you're exactly right. That's what mathematically should be the case. Now, several things. One is there's been a post hoc analysis that's looked at and tried to evaluate the clearance of the drug out of the eye. And clearance means sort of a proxy for half-life. And what the scientists at Regeneron did was they looked at 17 different trials that used aflibercept, intravenous, intravitreal, and subcutaneous. So all sorts of trials. And then they did mathematical modeling to go back and determine vitreous concentrations over time based upon the kinetics of all of these trials. And what they found was that there was not only the quadruple dose, but there was slower clearance, which means the half-life went longer, which we don't know why. But you'll see data that says 34% longer, slower clearance. We don't know why that's the case, but that says that you get two effects. One is the quadruple dose, the other is the longer durability. And that might explain why the extra durability that we're seeing, that's beyond what you would predict by 2 half-lives, which is a very reasonable prediction. People who, before I go off any further, there is precedent for that. And if you look back at 2005, there was an article by Godrold from Genentech where they looked at monkey eyes. And at that time, they were looking at 2 doses of ranibizumab, 0.5 and 2, so quadruple dose. And they did 2 different monkeys, and then they determined the pharmacokinetics. And what they found in the 2 milligram eye was not only do you have the quadruple dose, but you have a slower clearance, very much like seen in the pulsar data. So there may be a truth to that was seen both in monkey eyes and now in human eyes, where you quadruple the dose and you extend the half-life. So we don't know. Now, the critics will say that when the way the study was trialed, you didn't subject the 2 milligram dose to the same criteria of extension and shortening as you did the 8 milligram. And so you're not exactly comparing apples to apples, if you will. And that's a valid comparison. I think nobody disputes that it's longer. The exact length of the difference, we don't really know yet. We know what the trial showed us, but we don't know if that's a fair comparison.
So probably 2 more explanation can be there. One is 2 milligram was not sufficient enough to control the total free VEGF level, which 8 milligrams is controlling now.
Better, yes.
So that is probably one reason. Another is because all free levels are completely saturated, being trapped by this aflibercept. So probably the initial, the VEGF effect or the disease drying effect and the disease modification by the initial 8 milligram is there, so that to come back again to the 2 milligram level, so it is not coming to that level. So the disease is already modified during that initial 20 days time.
And that's probably true. Whatever that disease modification process is, that we still don't know to this day. But to get the disease under control quickly and change the natural history of that, you probably increase that with 8 milligrams compared to what you get with 2 milligrams. And hence you get an effect from that. I think you're right.
So, one question regarding diabetic nephropathy.
Yes.
In that case, how to manage? In that case, where the nephrologist doesn't want to give permission.
So yes, this is a very Indian question. And by that, I mean, I've had that question asked of me at every site here in India. I've never had that question asked of me by the nephrologist back in the US. So, how often does diabetic nephropathy occur? Well, how often does nephropathy occur in patients receiving anti-VEGF because of the anti-VEGF? And I think the answer is it probably is cases, meaning very few circumstances. So let me ask a question of the audience. Show of hands. How many of you have cases where you've treated intravitreal anti-VEGF and you believe that it has worsened kidney function? How many?
We don't believe the nephrologist.
Okay. So I have one case that I think occurred that way. And it was a patient receiving, of all the drugs, which do you think might be theoretically the safest drug for the kidneys? Everybody would say ranibizumab because it has a short intravitreal half-life. It was a patient taking ranibizumab, which speaks to the fact that all these drugs sort of behave the same. And the patient took the drug, the kidney function went down. Got off the drug, the kidney function came back up. Was re-challenged, and the kidney function went down, and then came back up again after stopping. So it's the only case I think we've ever seen that I feel comfortable saying that's probably the case. We switched drugs, and it was fine because it was only ranibizumab. So I think it might be drug, if it exists, and I think it's rare. As you say, the nephrologists think that, but we don't. So I think it's a rare circumstance, and it might not be VEGF related, it might be idiosyncratic drug related. But I would push back on the nephrologist, and I would say, are we sure this is the case? So, show me data from the literature and show me data from this patient that suggests that the anti-VEGF is the problem. And just say in our literature, and especially when we look at the big trials, because the big trials all looked at creatinine as a proxy for kidney function, and they never found any changes, including the diabetic patients. So they've all been studied. And when you look at adverse events and adverse side effects, you never see worsening kidney function. And that's when we're talking about treating 1,000 patients with the anti-VEGFs. So I don't think it occurs except for very, very few patients. Now, if the nephrologist pushes back and you have good data to suggest that's the case, then you're probably going to be giving Ozurdex or a steroid. But I think that's very rare it happens. And I would push back on them.
Sir, I have a question. So there's a patient. She's in her first trimester of pregnancy, and she develops BNN, branching neovascular pachychoroid neovasculopathy. So how do you go?
Oh, I was hoping you'd say diabetic retinopathy. That's what I'm hoping you'd say. So that's a tough one. And so let me back up and tell about a patient that I had with diabetes, and then we'll sort of jump over to the pachychoroid question. I had a patient who was diabetic and presented with mild diabetic retinopathy. By 3 months, the retinopathy got substantially worse, but her visual acuity was okay. And I followed her monthly, and it kept getting worse, and cotton wool spots and hemorrhages. But her central subfield thickness never got above 310. Her visual acuity never dropped below 20/30. So as a result, I followed her. And within 1 month after delivery, almost all of the diabetic retinopathy changes went away. And I never treated her. So it made me go back and look in the literature and say, what's the risk of giving an anti-VEGF agent during pregnancy? Well, of course, nobody wants to do that, right? So you've really got to look at sort of cases that have been presented where the patient was never known to be pregnant, but it was given, and what happened? So what Phil Rosenfeld published this article, and it was 20 cases from the literature. And in all those cases, it was given early on because the patient didn't know they were pregnant. She was pregnant. And over time, 3 or 15% of those patients had spontaneous miscarriage after receiving anti-VEGF. So 3 of 20, 15%. Now, we have no obstetricians here, but what's the risk of having a spontaneous miscarriage after the first trimester? 15%. So at least it's the same if you look at it that way. So we can't even suggest in the literature that it's a problem. So that being said, what do you do with the pachychoroid patient? I would probably approach them like I would approach the stroke patient. And I would say, theoretically, if I give you this, there's a theoretical chance it's going to interfere with growth of the fetus and placenta. But the numbers we have from the literature says that's probably not true, but they're not really good numbers. But I would suggest we follow you on a monthly basis. If the vision starts to go down, we'll do as few injections as we can get away with. That's probably what I would say. While explaining there is a risk, what is the risk? Well, it kind of depends on where in the pregnancy she is, but probably 15% chance of miscarriage. That's the way I would do it.
I would like to request, I think
well, yeah, heterogeneity, placental growth, so the whole works. Now, if it's a diabetic patient, then it's a different story. Because now you have 2 options. You have more options. Well, some more options. You can do laser, you can do steroids, or you can do nothing. Because if you wait 6 months, do you have a good chance of getting the vision back that was originally lost from diabetic macular edema? And the answer is yes, you do. So I'm going to ask a question here, and I'm going to invite answers. How long is a safe period of time to wait in diabetic macular edema before you've waited too long for the vision to come back? How long is safe? How long is too long? Anybody have an answer? I'm putting people on the spot. I know.
Till the patient is maintaining the same vision.
Yeah, till you're not able to get the same vision back by treating him when you start.
Correct.
How long? So, anybody, any guesses? I have an answer that I'm going to give you.
Okay.
So my answer is this. So I can't give you an exact answer, but if you look at the phase 3 trials for ranibizumab and for the VIEW trials, what did they do? Well, they did 2 treatment arms, and they did 1 arm of laser only. And then after 2 years, the laser only arm was then given anti-VEGF, and they improved a couple of letters and then leveled out, and they never got back to where the treated groups were. So that was 2 years of waiting. Now, the RESTORE trial was ranibizumab phase 3 in the Eastern Hemisphere, and it was the registration trial for ranibizumab for diabetic macular edema. And in the RESTORE trial, they did 3 arms. They did ranibizumab only monthly, they did ranibizumab monthly plus laser, and they did laser only. But their laser only was 1 year. So 1 year of laser only, and then they started ranibizumab. And by the end of year 3, they caught up to where the ranibizumab groups were. So my answer is 1 year is probably safe. 2 years is probably too long. So it's somewhere in between. So if you have a patient who's diabetic and they come in and they have diabetic macular edema 3 or 4 months, you should be able to wait until after delivery and then start them on therapy. It's going to take a while to get the vision back, but you should get it back. Pachychoroid's a different story. Pachychoroid's much tougher. And then I do that, as I said, I go down the arguments of the stroke issues.
I will request Dr. KP Ghosh, sir, if you just put a conclude remark and give vote of thanks.
Well, surprise after surprise after hearing your beautiful lecture.
Thank you.
Yeah. And we had a very wonderful time with you. And I really feel that queries about anti-VEGF will never end, and your answer, constant endeavor to make us understand the different questions put to you is really wonderful. And at the same time, I thank Bear for organizing such a beautiful conference and inviting you to come from that distance place to make us rich in this subject. Thank you very much.
Well, thank you.
Thank you. Before we leave for dinner, I'll request everybody to come for a group photo with Professor Stewart.